then there's an increased workload of the left ventricle. So there's an increased ventricular workload. Now, what happens when a muscle has an increased workload? Well, the muscle cells get bigger. There's a hypertrophy. So you get a left ventricular hypertrophy. And the heart enlarges. You get a cardiomegaly. And as the left ventricle gets bigger, as it hypertrophies, it's able to pump more. It actually gets stronger for a while to pump against the increased peripheral resistance. But after a certain amount of time of hypertrophy, the cells, as they get bigger, actually become weaker. So left ventricular hypertrophy will ultimately give rise to left ventricular failure. If you have a left ventricular failure, that means you get a backlog of blood in the venous system. Now, the left ventricle gets its blood from the left atria. The left atria gets its blood from the pulmonary veins. The pulmonary veins get their blood from the lungs. So there's a damming back of blood, venous blood at higher pressure in the pulmonary venous system. Ultimately, that can give rise to pulmonary edema. So, increased ventricular workload leads on to ventricular hypertrophy, leads on to cardiomegaly, and ultimately everything that's associated with a left ventricular failure. These ones go together. Now, we've mentioned that you can get angina as a result of the coronary heart disease. You can also get angina, or certainly the angina can be exacerbated by the increased oxygen demand of the hypertrophied myocardium, also giving rise to angina. So the heart disease can be a coronary heart disease. This mechanism can give rise to a congestive cardiac failure, left ventricular failure, congestive cardiac disease. And there can be features of clinical features from the enlarged myocardium. Now, the next complication I want to consider is peripheral vascular disease. The hypertension causes disease in the arteries that supply the legs. And again, thickening of the coats of the arteries and the development of atheroma, thickening of arterial walls and atheroma, causing peripheral vascular disease, disease of the peripheral arterial vessels. Now, this can give rise to quite a few clinical features. For example, it can give rise to the pain associated with claudication when there is when the aerobic metabolism in the leg muscles changes to anaerobic metabolism due to insufficient oxygenation with insufficient blood supply. The accumulation of lactic acid gives rise to the pain of claudication. So what it means is these patients don't have a good exercise tolerance. They can walk a little way and then they get pain and have to stop. There's an increased incidence of arterial leg ulcerations in peripheral vascular disease. And these can be quite difficult to heal up because of the poor blood supply. And there's an increased incidence of things like peripheral ischemia and gangrene. And in extreme cases, it can even result in the necessity for amputation. So hypertension, causing peripheral vascular disease. So the hypertension causes the arterial disease, and the arterial disease causes the peripheral ischemia. Let's think now about the renal complications. Now, hypertension will damage the renal blood vessels in the same way it damages all blood vessels. So there will be a narrowed lumen of the renal vessels. If there's a narrowed lumen of the renal vessels, this will result in a renal ischemia. There won't be enough blood getting through to the kidneys. Now, glomerular filtration, the formation of the glomerular filtrate from the glomerulus in the Bowman's capsule, depends on the pressure in the capillaries supplied by the afferent arteriole. And if this pressure drops, you get reduced glomerular filtration. So when there's renal arterial narrowing as a result of hypertension, it's reasonable to assume that you get reduced glomerular filtration rates. If you get reduced glomerular filtration rates, that means you don't excrete as much water and sodium because you're not forming enough glomerular filtrate. So you can get retention of water and sodium. If you retain water and sodium, what are you going to do to blood pressure? Well, of course, you're going to increase it. If you increase blood pressure, you cause more hypertensive damage to the renal vessels. So it's possible to get a bit of a vicious circle set up here. So renal complications, hypertension narrows the lumen, resulting in renal ischemia, resulting in reduced glomerular filtration, resulting in retention of water and sodium, resulting in increase in blood pressure, and of course that feeds back up to the top, which presumably makes the lumens even more narrowed. So possible to get a bit of a vicious circle set up there. There's actually another way this works. If you get a renal hypoperfusion, the pressure of the blood in the kidneys will drop, or certainly anyway if you get a renal hypoperfusion, that's detected in the juxtaglomerular apparatus that we talked about at the start of this video, and you get excessive secretion of renin. And remember, renin triggers off the renin-angiotensin mechanism, and the angiotensins will increase blood pressure. If you increase blood pressure, you get increasing damage to the renal vessels. So again, you can have a kind of a vicious circle set up here. So the renal hypoperfusion will lead on to the secretion of renin. The renin will increase blood pressure via the mechanism of the renin-angiotensin mechanism. And because you get increased blood pressure, you can get increased renal vessel damage, increased blood pressure, increased renal hypoperfusion, and so the vicious circle goes on. Now, when the renal ischemia is pronounced, and if it's prolonged for a period of time, you'll start actually getting hypoxic damage to the nephrons themselves. Ultimately, nephrons will start to die. So the renal ischemia can lead on to death of the actual nephrons themselves. This gives rise to renal atrophy, and renal scarring. So there is progressive renal atrophy and renal scarring. Ultimately, this will lead on to a complete renal failure, progressive renal failure. So a very serious complication, renal failure, and of course this is an immediate life-threatening condition. Now the last specific complication I want to talk about is retinal damage. Damage of retinal vessels can occur due to the hypertension, and the pathology in the retinal vessels is the same as we've talked about in other blood vessels supplying other parts of the body. The combination of the high blood pressure and the damaged vessel walls can lead to, not surprisingly, hemorrhage. So you can get retinal hemorrhages. The presence of the blood in the retina, of course, is going to damage the remarkably sensitive retinal cells. So you get retinal damage leading to visual loss. So there can be progressive visual loss. Sometimes the retinal hemorrhage can occur quickly with a marked deterioration in vision acutely. Other times the visual loss can be more progressive. And the state of the vessels in the retina, many people say, is a good indicator to the state of the blood vessels in other parts of the body. So retinal damage, damage of retinal vessels leading on to hemorrhage, retinal damage and visual loss. And the retinal vessels do seem to be a good indicator of the state of the blood vessels in other parts of the body. Now, if hypertension is managed, if a patient is prone to having hypertension and due to changes in lifestyle factors, possibly with the addition of medication, if you are able to keep the blood pressure down at normal levels, then they won't suffer from these complications. So it's not the predisposition to hypertension as such which causes the longer term complications, it is the actual hypertension itself. It is how high the blood pressure is for how long. So I've called this section advantages of treatment. Advantages of management might be a better term because it's not just treatment, not just giving out hypotensive medication. It's actually helping the person to live a healthy lifestyle, bearing in mind the lifestyle factors we looked at earlier. So what are the advantages of managing high blood pressure? Well, they are significant. You get reduced end organ complications. The damage that we've talked about to organs, if the blood pressure is low, won't occur. Or even if you can reduce the blood pressure, it will occur much more slowly. So you certainly get overall improved survival figures if you can manage the hypertension. Now, in severe hypertension, 80% 2-year mortality in very severe hypertension. What would have been an 80% 2-year mortality, in other words 80% of patients would have died within a 2-year period, with treatment becomes an 80% 5-year survival. So we've changed it from an 80% mortality over 2 years to a 20% mortality over 5 years. Very significant, very worthwhile. Great advantages there in treatment. Strokes. Hypertension is a major factor in the causation of stroke, and good management of high blood pressure can reduce strokes by probably more than a third, 35 to 40% reduction in the risk of having a stroke with managed hypertension, if the blood pressure is kept at reasonable levels. As well as making stroke less likely, myocardial infarction is also quite a lot less likely. Now you hear a lot of different figures. In one sense it doesn't matter too much, because we know that if you reduce blood pressure you reduce the risk of coronary heart disease, and that is always worthwhile. But in older people the risk is probably reduced by 20 or 25%. Again, you see different figures. Overall, the reduction in the likelihood of myocardial infarction occurring is probably about 16%. So advantages of treating hypertension are really quite significant. So there's a few figures there for some complications, but of course if you manage hypertension you're not going to get the peripheral vascular disease. You're not going to get the retinal damage and the retinal hemorrhages. You're not going to get the left ventricular failure, and you're not going to get the renal failure. So the more hypertension can be managed, the less the risks that these complications will occur, the less the risk that the individual will suffer from these complications. There's a lot of pathology here that with good management, you working together with the patient can be prevented. Now, just before we conclude this talk on hypertension by looking at treatments, I just want to mention a few investigations that the patients might have. Normally these patients would have a chest x-ray. On the chest x-ray you can see things like if the heart is enlarged, if there's a cardiomegaly. And an ECG, of course, is a very non-invasive, cheap investigation. It can tell you quite a lot about the health of the heart, and also it can tell you if you have a hypertrophy of the myocardium. Echocardiography is fairly readily available these days. It can tell you if there's cardiac failure, if there's cardiac enlargement. Echocardiography, quite useful. Again, a very non-invasive procedure. Urine, of course, should be tested for protein that might indicate the onset of renal damage, and also urine should be tested for sugar. Renal function tests can be carried out, blood tests to see if there's any renal damage, if there's any progressive renal failure. And three final things that should be done. The blood should be tested for cholesterol levels, because if someone is hypertensive and has a hyperlipidemia as well, as we saw before, there's a synergistic effect on risk factors. A person should be tested to make sure they're not diabetic, because again, these things all contribute towards the arterial disease. So we should look for other risk factors so they can be treated. Obesity, for example, can be a risk factor, and that can be managed, and we mentioned that in terms of contributing towards the hypertension itself as well. So look for other arteriopathic risk factors and treat those. And the final investigation I'm going to mention is asking if the patient smokes. Patients that are hypertensive should not smoke, as again it is a synergistic risk factor. The very last section of this talk, I want to consider some treatments, and we're thinking about pharmacological treatments, drug treatments. I'm not going to mention them all, just some of the more common ones. But before we do that, let's notice that in all patients, secondary causes should be excluded first. So in any patient presenting with hypertension, the possibility of there being a secondary cause should be excluded. Some would argue that this is particularly important in younger people who you wouldn't normally expect to be hypertensive, but it's true in everyone. So don't assume it's essential hypertension until the causes of secondary hypertension have been considered and excluded. Now, another very important point when treating blood pressure is to teach patients that are asymptomatic that treatment is important. Because when someone is feeling fine, then normally the last thing they want to do is take a drug. And I suppose it's a general principle really that we don't treat people who are feeling well. But this is very much an exception. And we know it's an exception for the evidence that we've looked at in this talk. So when people are diagnosed as being hypertensive but are asymptomatic, you've got to persuade them how important it is to treat the hypertension. Really, we need to point out the complications that can occur, but tell them that we can avert these complications, we can prevent these complications from occurring with good early management of the hypertension. Now, any drug treatment will need to be combined with changes in lifestyle and promoting a healthy lifestyle. We talked about the lifestyle factors: lack of exercise contributing to hypertension, excessive alcohol intake, and the other things we talked about, obesity. So any drug treatment should go hand in hand with good lifestyle factors. Drug treatment is not a substitute for bad lifestyle. So we're ready now to think about antihypertensive drugs. What type of antihypertensive drugs can we take? Again, take time to explain the benefits of this, because sometimes patients suffer from side effects from these drugs, and the side effects are immediate, whereas the long-term benefits are, well, long-term. So, really persuade the patients that this is important. So, excluding secondary causes, persuade asymptomatic patients, improve lifestyle factors, and then think about antihypertensive drugs. Now, in drug therapy, we need to think about the patient compliance. How well is the patient going to obey the instructions that we've given them? And this is very important in antihypertensive therapy, because when the patient starts taking the therapy, normally they feel fine. They have no clinical symptoms. The benefits are somewhat abstract and long-term in the future. But the complications, not the complications, the side effects of the therapy, the patient can feel those straight away. So it's very important to explain how important good compliance is. Now, what is the object of treatment? What are we trying to achieve? Well, obviously, any reduction in blood pressure is going to be beneficial. However, a kind of rule of thumb is that we want to get a systolic blood pressure below 160 and a diastolic blood pressure below 90. Now, we've seen that both of these can be important individual risk factors. So to try and get a systolic of below 160 is desirable. A diastolic below 90 millimeters of mercury is desirable. Now, treatment should normally be commenced at the lowest dose in the range, and then the patient carefully monitored so that the dose of drug can be titrated. So when a patient's first started on therapy, you might need to check the blood pressure fairly frequently to see if the dose needs to be adjusted. Now let's think about first-line treatments, the treatments that would be normally tried first. Diuretics. Normally a thiazide-type diuretic, such as bendrafluorozide, 5 milligrams daily, can be quite effective. Now, thiazide type diuretics are normally fairly mild and they promote a moderate diuresis. This means that the patient will excrete more water and more salts. This means the volume of the blood will be correspondingly lower. And if we can lower the volume of the blood, we can lower venous return and we can lower cardiac output, so we can lower the blood pressure. As well as that, actually, thiazide diuretics probably cause some direct arterial vasodilation. And if you get direct arterial vasodilation, you will lower peripheral resistance, therefore you will lower blood pressure via that mechanism. Now, with some types of diuretic, the patient excretes too much potassium and can become hypokalemic. Obviously a potentially serious side effect. But with thiazide type diuretics, like benzoyl, then normally hypokalemia is not a problem. But if hypokalemia does become a problem, a lot of people think now that it's better to give a potassium sparing diuretic, such as spirolactone, along with the thiazide diuretic, in preference to giving potassium supplements. So hypokalemia, not normally a problem with thiazide diuretics, but if it is, consider giving a potassium sparing diuretic in addition. Now, beta blockers are another effective treatment. And actually the mechanism of action of beta blockers, how they actually work, is a little bit unclear. They probably do in fact act via the central nervous system, but it seems they also reduce renin production with the consequent effects on the angiotensin mechanism. And they probably reduce the force of cardiac contraction to a degree as well. But however they work precisely, they are effective in a great many patients in reducing blood pressure. Now, there are quite a few other treatment options. I'm not going to go into them all on this talk. Let's just notice three other ones. The first is the ACE inhibitors, angiotensin converting enzyme inhibitors. Now, these drugs prevent the conversion of angiotensin 1 into angiotensin 2. And remember that angiotensin 2 is a powerful peripheral vasoconstrictor, so it increases peripheral resistance, therefore it raises blood pressure. ACE inhibitors probably suppress aldosterone secretion as well, actually. Remember, aldosterone increases the reabsorption of sodium, and sodium, being an osmotic molecule, attracts more water into the intravascular compartment, into the blood, so it increases overall blood volume. So ACE inhibitors can also slightly reduce blood volume. Angiotensin 2 antagonists. Now, the angiotensin 2 fits into particular receptor sites on the walls of the arterioles, and when those receptor sites are stimulated by the angiotensin 2, it causes the peripheral vasoconstriction, which is the associated effect, or the effect associated with angiotensin 2. And angiotensin 2 antagonists, an antagonist, remember, works against, so they will block that transmission directly, therefore have an anti-hypertensive effect. And I think the last group of drugs that I'll mention are the calcium antagonists, calcium ion antagonists. These block the inward flow of calcium into muscle cells. and calcium is essential for normal muscle cell contraction. So if you reduce the amount of calcium going into the cell, you reduce the ability of the cell to contract. Therefore, you can reduce the overall tone of the muscle. Of course, there is smooth muscle in the medias, in the walls of the arterioles and arterial vessels. So this will reduce the muscular tone in the peripheral vasculature. If you reduce the muscle tone in the peripheral vessels, you essentially get a vasodilation. And if you get a vasodilation, you will reduce peripheral resistance. This has been quite a long talk actually on hypertension. If you've got through all of this, my congratulations, you've done well. But of course, like all talks and all textbooks, as soon as they're given, essentially, they are somewhat out of date. Now, the principles I've talked about in this video should stay the same, so you can use these principles to inform your more up-to-date reading and up-to-date study of this area. Then you can use this information to prevent people suffering from the complications of hypertension, and that is important.